It is my great pleasure to introduce Dr. Adewale Troutman to be our keynote speaker this morning. We've known Dr. Troutman for a long time. It was in the last decade sometime when we couldn't decide exactly which year, but our first meeting on the social determinants of health here in Columbia, he was here. Some of you will remember. That was a great event, and we're delighted to have him back. He has a long and distinguished career. You can read his bio in your packet. He's a family physician. He's been a leader in academic health centers. He's been a public health leader, and he's been a hospital administrator. So Dr. Troutman's really done it all. Many of you maybe met him for the first time when he was a leading voice in the breakthrough documentary called Unnatural Causes. So I think many of you met him maybe for the first time there. He's excited about the fact that he's the immediate past president of the the Public Health Association. And I think his president year was very busy, and so he's immediate past president of that organization. He currently is Associate Dean for Health Equity and Community Engagement at the University of South Florida College of Public Health, and is doing some really exciting work across the country with other centers of health equity and other folks interested in the issues that face us today. So it is my pleasure to introduce Dr. Adewale Troutman.
Thank you and good morning. It is a pleasure to be back in Missouri. Last time I was here was in St. Louis, and then we were here several years ago as a part of your work that you're doing. And we're very pleased and excited to be back here. After a drive, 2 hours to get here yesterday and a short plane flight, we are certainly happy. We do it again at any time. So I wanted to spend just a couple of minutes and talk to you about what it is and what we're not going to do this morning, and what your any preconceived notions might be. We are not here to have a political discussion, that is in parties. We're not pitting Democrats and Republicans and liberals and independents. It's not really going to be a lecture. I want it to be more of a conversation. You guys are doing a lot of great work, and we need to just share each other's passion and information. This is not a racial discussion per se, although race plays into the differences in health outcomes by groups across the United States. And certainly we're not going to bash the medical model. I spent my early part of my career as a clinician, 15 years in emergency medicine in clinics, and I understand the significance of the medical model, particularly its gratification in working with one-on-one and small family units. So we're not going to bash it. And this is not just an academic exercise. I do want this to be a talk that inspires and motivates you to continue the work that you're doing and perhaps expand into new areas. So this is the rest of my family. You heard my introduction, or some of it anyway. This is the rest of my family. These are my two brothers and my mother. This is obviously a long time ago from the clothing that we're wearing. My mother is now today 96 years old, still lives in the Bronx, in Co-op City. I used to say she lives by herself, but now she has a 78-year-old boyfriend. And she had some issues a while back, and we talked about perhaps needing to be in a facility because she was having some difficulties, and did some investigation. She eventually said yes, assisted living would work for her. And I called her one Saturday morning about 7 a.m. to say, okay, Ma, we found a place. I think this is what we need to do. And she said, well, Preston, this is his name. Said, Preston is now coming over 4 or 5 times a week, and I don't think I need an assisted living facility. So I said, okay, Ma, I tell you what. You tell Preston if he doesn't take care of you properly, I'm coming to the Bronx and I'm going to kick his butt. And she said, oh, you can tell him yourself. So we finally called my mother the original cougar at 96, a 70-year-old boyfriend. So being born in the South Bronx, my background is of a poor kid in the South Bronx. And I always said we were so poor, we couldn't afford the OR in the end, so we were just PO. It was the 50s and 60s, so there was nationally racial tension, racism, discrimination, murders, et cetera. In my own experience, in my own home, unfortunately, I had the experience of seeing an alcoholic father who abused his wife, my mother. My brother's waiting behind the door to beat him up one night because he had hit her. That was the last time I saw him for many, many years. He didn't come back that night. So my experience of growing up in the Bronx with a single mom and two brothers in a poor environment is not academic for me or something that you could conjecture. It was my real life and certainly shaped all of what I do today and why I do that. But the things that really made a difference in my life, that impacted me dramatically, of course, were the movements at the time, civil rights, human rights, the movements across the African continent for liberation, the sense that one person really can make a difference. And one of the messages that we certainly want to drive home this morning to all of you and to each one of you is that every single individual has the power to make the dramatic difference and perhaps even change the entire face of the world or the universe if you want to go that far. It's just about recognizing that and stepping up to the plate and claiming the power that's within each one of us and using it for the things that we believe are of course, important. The notion that I really can change the world is a major driver in what has been a part of my life for the last 60 or so years. And as we thought about that, and some of the figures in history, we automatically say, oh, what great people, they just did such magnificent work, and think that somehow they are different than you or I. And some of the names that we're familiar with, Malcolm and Martin Luther King, of course, Steve Jobs, we were talking about some of the dramatic changes in communication across the globe that have happened because of the result of one man, one person. And of course, we said we have to add that based upon the work that's going on here, Shannon Canfield and Dr. Karen Edison. And I'd like to give them a round of applause for the hard work that they're doing and the visionary work that they're doing that we believe is going to make an ultimate difference. So a recognition that we are all connected is a part of this thought process. And if you haven't thought about it, think for a minute over the past 10 years or so. There was SARS, which started in Asia someplace and spread across the world. There was West Nile virus, which all of a sudden found its way from the Nile Valley in Egypt to the Bronx and New York City and other parts of the United States. There's H1N1, all the work that we did a couple of years ago around the potential of flu epidemic, the spread of technology, natural disasters, tsunamis in Asia, wash up on the shores of Alaska and the west coast of the United States. Everything is connected. Even we look at Deepak Chopra in some of his more recent discussions, who says, when I breathe out molecules of metabolism for stress or anger or happiness or joy, you walk into the room and you breathe in the molecules I breathe out. So we're very, very much connected, and we should keep that in the forefront of our mind as we think about how we do the work that we do. Even my favorite philosopher, Mufasa, and this is why I challenge James Earl Jones to a duel, because I'll say to Mufasa says, we are all connected by the great circle of life. Now, couldn't you imagine me saying, this is CNN? I'm waiting for that phone call. Connection, again, is critically important, and we think it's important to ensure that connection, to build on that connection. We have to be willing to disregard regionalism, and this is a specific comment based upon some of the conversation we had last night around the regionalism in the state. Not just this state, it's really across the country. We're here in Missouri. Come to terms with our own individual isms. That is to say, getting engaged in a process that encourages you to look very, very deeply into who you are, and honestly make an assessment of who you are, and think about the isms that you may find, whether it's racism, ageism, sexism, homophobia, or whatever it happens to be. Take our own leadership seriously. Genuinely believe in the possibility, and most importantly, break out of your silos. You know, I spent many years in clinical medicine. I thought there were silos in clinical medicine until I got to academia. And then there were silos within silos within silos. And in the very middle of that silo, a researcher who didn't know anything else about anybody else in the universe but his or her project, and that's all they wanted to hear about, even though there's a recognition that you can't solve the problems without being out of silos and working together in a common space like this, which is what you're going to be doing today. So it's extremely important. Do not fear change. That's one of the kind of difficult elements for us to think. We're afraid of change, but change is good. Embrace change, celebrate change. And last but not least, there is no them, there's only us. A principle that if we could find a way to believe in, none of this work would be difficult at all, because we would all be connected to everything that happens to everybody else. There is no them, there's only us. And that's a way to create a collective conscience around the issues that we're talking about. So we recognize that Martin Luther King was a great man, and one of those power of one figures that we talk about. And we know about his work in civil rights, but this is what he was said in relationship to the work that we do now, that of all the injustices in health are the most shocking and inhumane. Then it behooves us to think about, well, how do we reframe the work that we do so that it fits right into where we are in the 21st century? How do we reframe a discussion around health versus healthcare? So that a recognition that what we're talking about is the broad spectrum of health that includes all the things that affect health: transportation, education, housing, racism, discrimination, lack of access, joblessness, all the things that are about health, not just health care, which is going to the doctor or the clinic or getting, excuse me, diagnosis, management, treatment of disease and illness. So reframing that larger conversation. And how do we look at this notion of language around the work that we're all doing? You know, we're still using, and as I travel around the country, a lot of people are still using health disparities elimination as the hallmark of the work that they do. Well, health disparities, by definition, just means differences. It doesn't go into the depth of what is critically important and discriminatory and exclusionary about what we have today. There's another word that we need to find a way to use, and that is to focus on equity. And we'll talk in a minute just some very brief definitions to remind us of what it is we're talking about. The longest definition probably I've ever put on any slide in the history of the universe. But and this is the definition that we've been using for maybe 10 years or so from some work around the country. And as I thought about putting parts of it on the slide, I said, let me put the whole slide down and highlight the most important elements of this. You certainly can take your time and read this at your leisure. But the important elements of this definition of health equity, which is what we're all doing, is that it focuses on all people, the highest attainable level of health, focused in ongoing societal efforts, assuring the conditions for optimal health, and particularly for those who've experienced historical or contemporary injustice or socioeconomic disadvantage. So from a contextual standpoint, I think this definition is very, very powerful. And if we use this definition for the work that we do, it'll help to bring us all together. Now, one of the things I found in the work I'm doing around the country is that of the 28 or so universities that we've identified thus far, probably not 2 or 3 of them are using the same definition. They're very, very, and that's an important element of the work. We need to be on the same page, and if we're going to find the same direction to the same solution. So we're constantly working on espousing this particular definition. And the flip side, the definition of inequity, which is another term that we prefer to use in our work, and I yellowed out the important elements. That is systemic. So it's not just outside into the incidental. It's systemic. It's avoidable, it's unfair, and it's unjust, and it's sustained over time and generations, and it is beyond the control of individuals. So again, it puts it in the context of social cohesion and organized work to do the work that we need to do to bring about equity and eliminate health inequities all across the country. And I love this quote. There are a couple that have come out through the work over the years. This is from the Commonwealth Fund. It says, ensuring access to quality, affordable health care service is not merely a matter of system reform. It is a matter of human dignity and of national wellness. So we're back to the discussion of human rights. Many of us in this work are very proud to say, without question, health is a basic human right. It sets the agenda, it sets the stage, it sets the priorities, it sets the need for resources to address the issues in an organized, cohesive way. If it is a right, as we suspect that it is, and we say that it is, it orders the steps that must be taken by all governments, local, state, and federal, and regional, to make sure that everybody has an equitable opportunity to benefit from that right. By definition, if you have people who are not connected to the right to life and health, then there is a human rights social justice issue automatically by definition. And you can say, if you want to take it to an extreme, that the existence of those differences is in fact a violation of human rights. And there are some who have tried to take this to the United Nations on the behalf of the people of this country, that there are human rights violations inherent in the differences in health outcomes and status across the United States. A summary of what the human right is, sometimes we take this for granted, and I just wanted to mention a few things that, by definition, human rights are universal. They're a birthright. They're inalienable, means you can't take them away. They're interdependent. If one of them is abridged, they're all abridged. They are entitlements of individuals, and they're internationally guaranteed. That is a summary of what a human right is. So when we talk the language, this is the things that we're talking about. WHO, in its Constitution in 1948, wrote this particular piece in the preamble. The enjoyment of the highest standard of health is one of the fundamental rights of every human being, without distinction of race, religion, political belief, economic, or social position. Sometimes we get into arguments and discussions and say, well, it's not a right. It's not written down anyplace, so it's not a human right. Well, WHO says it is. There are 115 or so countries around the world that have it in their constitution, either as medical care, health care, or some combination of the above. And the notion that it is a constitutional guaranteed by birthright is spreading across the world. And I think the United States is a little behind in this effort, and it's something we ought to take a look at. Another quote that I think is really impactful, that it affects all of the work that we do. There can be no hope for the spread of freedom, democracy, and human dignity unless we treat health as a basic human right. So you remember some years ago we talked about spreading democracy around the world. These individuals, European ministers, said, no, you can't, without focusing on the fact that health is a basic human right. And then there's the issue of justice. So is this an issue of justice? Yes, it is. Justice talks about fairness. That's a tough concept sometimes for us to address. Maybe in your small groups you might ask each other that question, what is fairness? But then you got to go down the hall and get some of the teenagers and say, yo, dude, what's fairness? So they'll let them ask you. Or maybe you have a teenager at home who said to you from time to time, Ma, that's not fair. The principle of moral rightness, equity are in the definition of justice, and then a conformity to that in action or attitude. The next level, then, being social justice, has taken the individual applications, the individual definitions, and raising them to the broadest level of society to focus on all of us. And it implies equity is actually in the definition, and I highlighted an equal access to societal power, goods, and services. Now, I did this definition a long time ago. WHO subsequently came out maybe 5 or 6 years ago and said one of the issues that we have to do is to find a way to rebalance the distribution of power, resources, and influence and money if we're going to have an equitable world in terms of health and health status. So it's an ongoing major issue that is very difficult to address, but one that we have to find a way to deal with. And in the document that they published, Closing the Gap in a Generation through the Focus on the Social Determinants of Health, on page 1, it says social justice is a matter of life and death. So that's the ultimate exclamation point on the severity and the seriousness of this issue. This is a good friend of mine. We had coffee together this morning. This is actually Albert Einstein, for those who don't know. And being as a brilliant man that he was, one of the things that he is given credit for, and paraphrase, is that if we continue to do the same thing in the same way and expect a different result, we're insane. That, in the context of our work, for my thinking, means that we've been doing medical model work for many, many years, thinking that somehow we can close the gap in excess death by working on individual interactions and getting, screening done, et cetera, et cetera, et cetera. That is not going to make the difference. The difference, and you've done this work around social determinants, is shifting the focus to this new direction, which is one that's exciting, bold, and risky, I'll admit, by focusing on social determinants as the primary focus of the primary work and movement that we have to do to close the gap and bring about an opportunity for everybody to have optimal health. This is our favorite metaphor, our favorite slide, because it highlights what the directions are, and I'll tell you what the metaphor is. You may have seen this before, I had this conversation, but I'll share it with you again. This is any river that you'd like to pick. I know we're right here in the heartland with the Mississippi and the Missouri and all the great rivers around. So we see several people, at least 3 or 4, standing on the bank of the river, and they're fishing on a Sunday afternoon. And without notice, a baby floats down the river. And they kind of get freaked out by this, and before they can do anything, a second floats down the river, and maybe even a third. The first man throws his fishing rod down and jumps in the water to save the babies. The second guy throws his fishing rod down and starts running upstream. And they call out to him while the other 2 are jumping in the river doing whatever they do. One of them is just trying to do something around saving these kids. They called him and said, where are you going? We need you to help pull the babies out the river. He said, well, I'm going upstream to find out who's throwing the babies in the river and stop them. So the metaphor for us is the upstream-downstream analogy, which many of us are familiar with, which is to say those babies in the river represent all the inequities that we talked about, whether there's health status issues, housing issues, educational issues, unfair rates of homicide, all of the things that housing difficulties, that's what's represented by the babies. So the one person who wants to pull the babies out is doing great work, but he pulls the baby out and another one comes down the river. One of them wants to educate the babies, teach the babies how to swim in the river, not pull them out, but just kind of keep them alive so they can just kind of subsist. And then, of course, there's the one who goes upstream to pull the babies out of the river, and that we say is the ultimate objective. One last piece of this is that probably we need to be on the bridge so all of us can be in the river. And that's where we all need to be. Some of us downstream, some of us upstream, depending upon your expertise and your interests, and some of us on the bridge helping to direct the movement that those who are in the river are doing so that we get the ultimate objective accomplished that we're looking for. So a definition of social determinants, and it's an important one because it talks about how complex, integrated, and overlapping they are, and that they're responsible for most health inequities. And here's a list of them. And you can make it your own list. There are lots of lists out there. I like this one because it's so comprehensive. Some of the ones that we're all working with all over the country, the issues of food and food deserts, food systems, food policy analysis, creating food policy groups at the local level, getting communities involved in finding solutions to the policy issue, the housing issues around segregation of housing by race and socioeconomic status, which dramatically affect the health outcomes, by the way, in a multiplied effect. The educational issues, my goodness, we recognize that education may be the most important social determinant of the health populations. There are others who say it's income. There are others who say it's actually gap in income, which kind of makes sense too, considering we have the largest gap of income of any industrialized nation in the world, and it's growing, as is the gap in excess death, which was at one point was shrinking, and it's now growing as well. We think there's a correlation between there. I had an opportunity to talk to the director of the YMCA in Louisville a while ago in an interview. And at the end of our discussion, he said to me, Dr. Troutman, if you could change one thing in Louisville to improve the health of the city, what would it be? I was expecting I was going to say, more clinics, walking programs, something like that. I said I'd make sure everybody graduates from high school because of the correlation. Interesting thought. Political power, definitely an issue. I think anybody who's working in this business who wants to push an agenda and gets pushback from the political power that doesn't understand or does not want to support your position, make it clear that political power is an issue. So part of building a movement, which we'll get to, is being engaged in the power identification. Where are the pockets of power? Who do you need to move to understand the issues so they can in fact be the advocate that you need at the legislature, state, or otherwise to make the significant difference. And last but not least on this, of course, is the continued existence of the effects of racism, both institutionalized, individually mediated, and internalized. Perhaps the document that you've all seen, certainly those who work in the health system, I'm sure remember this, unequal treatment by the Institute of Medicine, National Academy of Sciences, which was looking at is there in fact do we in fact have the existence of racism and discrimination in delivery of healthcare services in the United States? They looked at hundreds of studies and resoundingly said, yes, at every level, at every size, state, local, private, public, for-profit, not-for-profit, it's there everywhere. And we continue to find the need to address these issues. And some institutions have found a way to do it. This health system, I'm not sure where we are with that process here, but it's certainly one of the things that we ought to take a look at. Referral patterns by race and ethnicity, which is identified in the study as one of the big issues, and defining an instrument that helps you to define whether or not you have that problem in your healthcare delivery system is something that can be done, and the groups around the country have been working on that. Dr. David Satcher, who was the former Surgeon General and Assistant Secretary, brilliant man, really drove for years this notion of eliminating differences in health outcome. I had an opportunity to co-author an article with him called "What If We Were Equal?" And the notion is that what if there was real equity in the country? What would that mean in terms of the number of people who die from various illnesses and had lack of access to health care and insurance coverage? And that very impactful article is still being used across the country. So here's a summary for staying healthy, an approach of social determinants. Number one, don't be poor. If you can, stop. If you can't, try not to be poor for too long. Don't have poor parents. Don't live in a poor neighborhood. Own a car, but use it only for weekend outings. Walk to work. Practice not losing your job, and don't become unemployed. Don't be illiterate. Avoid social isolation, and try not to be a part of a socially marginalized group. Now, we can just do that, then we've solved the problem. However, WHO recently talked about how to operationalize looking at social determinants of health at the community level. How do we take the theory and the principles of social determinants and put that in the context of the real world? And they listed 5 elements. The first one was the issue of governance, which is something I hadn't really thought about. Governance becomes a major issue when you come to understand how do we, in fact, manipulate our systems of governance, whether at the local level, corporate level, foundation level, city level, state level, so that we, in fact, can do the work of social determinants that we have to find a way to do. So governance, you can't just jump into it without thinking about those very, very basic issues. What is a governance issue? How do you implement action on social determinants based upon the governance? How can we best promote participation? And that is getting community leaders for action on social determinants at all levels, to understand how important and critically this is, and that their engaged involvement is absolutely necessary to make a difference. Number 3, the role of the health sector, including public health programs, in reducing health inequities. How does the public health sector, the health sector, the healthcare sector, healthcare delivery, small clinics, big hospital systems, religious institutions like Catholic Health Initiatives and others, how do we all come together as a health sector to recognize that we have to reach out to all of the other parts of the health sector, the transportation, education, the housing, the urban planning, the community justice groups, et cetera, to do this work. Next, that this is in fact a global issue. We have a tendency to focus ourselves on the United States, which is of course understandable. But I remember I mentioned how connected we all are. Well, I think there's no more telling fact of that than looking at health issues around the globe. In the United States, U.S. is kind of a microcosm of the world, in that we have, poor folk, and we have middle-class folk, and we have a very, very small percentage of folk at the top who own everything. So they're the haves and the have-nots within the United States system, and the haves and the have-nots partly determine health status, health outcomes, and health issues around those populations. Globally, the haves are the Western states, Western nations, United States, industrialized countries in Europe, et cetera, and the have-nots are Africa, Asia, Latin America, developing countries. So this question of health equity on a global level is very similar to what we're talking about within the context of the United States. That is to say, housing, education, lack of access to resources, jobs, economic struggle and difficulty, all are part of what determines what happens to health outcomes. So we need to be a part of the overall global issue. When we think about health equity issues in the United States, we need to open our minds and think about how is the impact across the world, and vice versa. When you start reading about economic collapse in Zaire or in the Congo, does that impact in any way our economy and therefore our focus on health equity and social justice? And last but not least, one of the more difficult ones is monitoring progress. So we've been talking about this thing called social determinants for a while now, and health equity for a while now. And how do we know when we in fact have made a difference in health equity? There is at least one group in the United States, the Connecticut Health Officers Association, which developed something called a Health Equity Index that they have been using now for several years. It's been beta tested, field tested, and it's been running in several cities around the country, around the state of Connecticut. And wherever I go, I encourage people to take a look at that, see if it fits your situation, and how, if it does, how you might integrate it into your work so that you can have a reasonable way of identifying progress around health equity and the use of social determinants. There's also I think, a well-established belief that dealing with the social determinants of health may yield, it says may, but I think will yield greater and more sustainable returns. After all, sustainability becomes a major part of what we're all talking. How do we continue to sustain this work over time? So everybody around the table here today, I mean, I'm very excited about the breakout sessions you're going to have this afternoon, I guess, to take any theoretical conversations or thoughts you may have had this morning, and how do you turn them into action steps to move from wherever you are to wherever you want to be, just at least the next step. And the only way to do that is for everyone to be together without the silos, and open minds and hearts, and with a common notion that the ultimate objective here around the consciousness that we're trying to create is equity and social justice and human rights. Another long definition, please do not get upset about that, because I'm only going to focus on the highlighted parts. But health in all policies is probably something at least some of you have heard of by now. I know there's a Health Policy Institute here at the university, so I'm sure that there's been some discussion about health in all policies. The short version is that we in public health, who without question feel we are absolutely the best people in the universe, no doubt about it, we would like to be in control of everything. Because if we were in control of everything, we'd have all these elements and factors working together and humming like a good engine and moving down the line towards health equity. But we can't. We don't. We recognize that everybody has their own interests, and part of what the focus on health and all policies is to get them to understand the interconnections of all of us. That it's a win-win situation if we sit down with transportation and education and housing and find ways to work together. And therefore, there's a reason that we should do that. And that's essentially what health in all policies says, that there are other sectors other than health which are involved, and that social determinants work can bridge between policies and health outcomes. So we're strongly in favor of health in all policies and the work that we do. And again, highlighted in the yellow, key elements of this approach, it promotes health, equity, and sustainability. It embeds health, equity, and sustainability considerations into government decision-making process. So it actually requires a change in the way governments make their decisions to make sure they focus on the issues around health equity. It breaks down silos and builds new partnerships to promote health and equity and increase government efficiency. So there's nothing negative about it. It's all a positive understanding of what we can do. It benefits multiple partners in all sectors, and again, it's a win-win and co-benefits. It helps to engage stakeholders across the board. Community people, local politicians, practitioners, professionals, in all spheres of the community, there's an opportunity to engage them in doing this work. And it can create structural or procedural change that is permanent. So once we get through the work of getting this done, we can keep it going, but it's a permanent change, so therefore we know that we're going to have positive outcomes down the line. Some of the policy areas that we think remain critically important. Access to tobacco products. I thought about that one, and we're in a new phase of dealing with this question of access of tobacco products. Now we're looking at synthetic marijuana being sold at corner stores across the United States in very pretty packages with very cute names and very sweet-tasting materials that are causing havoc, I think, around the country. And now we're talking about e-cigarettes. No regulation, no nothing. And what's to say that we won't have the same push by the tobacco products? And when we get to a place where there's legalized marijuana, which is certainly coming across the country, that says that those industries are not going to do the same thing they did with tobacco in pushing it on certain communities, poor communities, communities of color, and youth to the detriment of all of us if we don't keep this back on the front burner. Housing policy, education policy, poverty elimination. A lot of discussion these days around economic development and health outcomes. The recognition that if you economically develop a community that is distressed with jobs, you're more likely that people will be working in those neighborhoods and putting money back into those neighborhoods, in fact, which improve the infrastructure, improve access to health care and health issues, transportation, housing, et cetera. So economic development becomes a public health strategy, if you will. And if we don't do that, if we continue with just the downstream work that we've been working on, we come up with just a short-term downstream policies, just develop a healthier underclass of poor folk. And if that's satisfactory to you, I think maybe you might want to rethink that. We don't want that. Just to say that we've increased, we lowered the blood pressure of poor people in the south side of Chicago, but there's still poor people in the south side of Chicago with no jobs and high crime rates. That doesn't make the difference ultimately, so we have to find a way to incorporate that thought process. Living wage is another one. So I've been traveling around the country for a while now and working with a lot of these folk, and I thought it would be of interest at least to let you know what some of the other people around the country are doing. First on this list is Louisville, Kentucky, where we spent 8 really great years. We opened the first Center for Health Equity at a local health department in the United States. So the primary difference is it was at a local health department, not a research-based Center for Health Equity, which it seems to me that so far most of the universities that I've talked to are primarily research-based. Research-based. We talked last night for a minute about this three-legged stool in higher education: education, research, and service. Those are the 3 things that we're supposed to be doing as universities, by the way. It also means in analysis that professors, people who work in the industry, should be able to get tenure based upon service as well as research and education. Many of our institutions don't do that. So, you can do all the service you want, but you ain't getting credit for it when it comes to promotion and tenure. How many grants do you have? How much money did you bring in? What kind of research you're doing? That's not ultimately the most effective way for us to do the work that we do. But our Center for Health Equity and the local health department did some really great projects. We did Health in a Hurry corner store projects, of Food Policy Institute for our youth, our citizens. Undoing racism training was something that we implemented in Louisville as well. So there's some really good examples there. Alameda County is California. It's Oakland. And the Oakland Health Department and others had a conversation within themselves as to function and structure. So everybody recognized that we need to find a way to engage communities and build community organizing efforts amongst local public health. Alameda County decided to create a unit in their county health department that was a community organizing unit. So they trained their staff in how to go out to the community and be about the organization of doing community organizing in the purest sense, to get people advocates and organized and ready to move and make changes. Seattle King County decided to train their outreach workers, as we did in Louisville, as community organizers, but not have a functional unit. So there was a function versus structure, and I think both are worth looking at. Seattle King County also did a fantastic job of community engagement around a Hope 6 project. Now, for those who don't know Hope 6, it's a federally funded project from HUD to tear down public housing projects, which have been a source of just terrible lifestyle and outcome issues across the country. In big cities, we think about Chicago, New York, Baltimore, but Louisville, Kentucky has them as well. They're only 3 or 4 stories tall, but they're equally devastating and not supportive of good health. So the Seattle King County Department met with the community folk all across Seattle around what is it that you want? We've got resources from the federal government to build new housing. What do you need it to be? And what they said was, well, we have a big problem with asthma in our community. We like big sidewalks so we can communicate with our friends and build social capital. We like front-facing porches so we can sit on the porch and say hi to our neighbors and be friendly to them. And this question of asthma became a really critical point. The housing authority, with the support of the community, then put special units together with special filtration systems in the housing units for those people who had asthma. So it became more than just an education around the signs and symptoms of asthma. And when you take my kid to the emergency department, they had a filtration unit that, in fact, had a better air quality in the apartment than outside the apartment, and those children went to the emergency department infinitely less. So Seattle-King County's role in engaging community with HUD resulted in this dramatically improved status of health in that community, particularly amongst kids who had asthma. The Boston Health Department decided it was going to take head-on racism, and built in structurally within the Boston Public Health Commission elements to identify and eradicate institutionalized racism in hiring practices, inclusion practices in the city health department, and is still doing that work in Boston. That's something else you can certainly take a look at if you want to find the Boston Public Health Commission and its effects on racism. We were in Kalamazoo. Kalamazoo, as a city, started a Center for Health Equity in their local health department, and then had this incredible public-private partnership around the recognition that education is probably the most single important social determinant of health, and found a way to create a project called the Kalamazoo Promise, which says that every child who graduates from high school in Kalamazoo, Michigan, gets to go to college free at one of their state institutions. And that's just revolutionary to me that a city could get to that point. They're still doing this work. They have some issues around making sure that all the kids are interested and engaged and want to go, but they make a major step in the right direction. We went to Portland, Oregon. Many of you may be familiar with GIS mapping, Geographical Information Systems. Well, Portland took it to the extreme. They have geographical information systems on everything, down to geographical areas that are several blocks. So not a county or a city, but several blocks. And if you're a citizen, you can go to them and tell them what you want to look at. You want to see what the what smoking frequency is in this small community, and they'll give you information on that translates into GIS mapping, so you can find ways to address the issues you want to address. GIS mapping, for those who've never seen it, is an extremely powerful product, an extremely powerful way of encouraging legislators at the local level to see what is difficult to translate into numbers. So the maps are different colors. You can overlay them one on the other, and it's very, very impactful. So GIS mapping is extremely valuable, extremely important. And then Oakland, California refers to a group called Change Lab Solutions, who has taken on the challenge of looking at policy initiatives all across the board that relate to health equity, social justice, and human rights. Most recently, they worked on something called joint use policies. Joint use is a discussion around communities being able to use public school facilities after hours for community fitness and community issues. So when these issues were first presented to school systems around the country, they were saying, no, we can't do that. It's a liability issue. You have people in the community on grounds after we're gone, and somebody gets hurt and we get sued. So Change Lab said, I don't think that's true, and they started doing research around policies all across the country and found, in fact, that it is not a liability issue. And then the really creative thing they did was to tell communities all over the United States, if you want proof that this is not a liability issue, you want an example of a policy brief that, in fact, can move this agenda, just let us know. And they've been sending them out all over the place. And they have a repository now of that kind of work in multiple issues around health equity and access to services. And then last but not least on this slide, we're just so encouraged by what we see here in Columbia. It's a question mark at this point because we want to wait and see to what happens this afternoon in your breakout sessions and all the great creative work that's going to come. But so far, I'm very enthused about what we've seen here in Columbia. Probably the most impactful thing that we did as a local health department in Louisville was get involved in this landmark series on natural causes. Hopefully, most of you have seen it by now. The Association of American Medical College said that we strongly recommend every medical school in the country use this documentary as a part of its curriculum and training. And I go further than that. I said every nursing school, professional school, everybody ought to take a look at this and see what is there for them. The opportunity to have community engagement improved by these discussions. One city that we know of, even there's a guide that comes with unnatural causes. One city that we know of actually took the documentary and said to the community, come up with a guide to educate others about this. So it's a community-based curriculum developed that this local community did around unnatural causes. Just an incredible idea. So we encourage, if you've not yet seen it, to take a look at it. If you have, to find new ways to use it amongst your constituencies, so that the community dialogue increases around this important work. So we talk about a movement, and civil rights is probably the most iconic movement that we know of. It did tremendous work. 1964 is the first, for those who don't know, 1964 is the first time we had a civil rights legislation that addressed the African American and others community in 1964. So that's not that long ago. But the civil rights movement, for what it was, didn't quite make it all the way. So now we're talking 1964, we're talking the Medicaid program, the Medicare program, federally qualified health centers, even some groups that are considered fringe groups, like the Black Panthers, the Puerto Rican nationalist movement in New York, all were talking about free healthcare clinics. That was a part of their basic offering, the recognition of how important this was. So we would have liked to see the civil rights continue to work, jump into social determinist theory, and continue focusing on this work. But building a movement is an important part of what we see as the next step. Throughout history, social movements have brought about the most significant changes for racial, economic, and gender justice. Social movements. So what we're bridging between an academic, community-based, service provider-based, local public health system-based, that turns into a movement that's a grassroots growing movement around health equity and social justice. And think about the labor movement, civil rights movement, the women's movement, gay and lesbian movement as examples, that they have in fact transformed our society's systems and structures. And we're talking about transformational change, basic gut level transformational change, and developing a collective consciousness around the issues that we think are extremely important. So building a movement becomes this iconic picture that we all have seen. We want to see the placards saying things that relate to the work that we do. So we want to see, one of the challenges I would ask you is the thing, well, what would be on your, if you were in a movement, in a march, what would be on your placard? What would you want to say? Maybe you can give that some thought this afternoon as well. But it's a long-term process. It is a grassroots process. Institutions like universities really can't, I don't think, have the legs and the ability to start and carry forward a movement. It has to be grassroots based with support of intellectuals, universities, communities like this. And I certainly encourage you to think about how do you work on organizing groups of people to intentionally spark and sustain the social movement. We encourage that you leave behind a more narrow vision and take up an expansive vision that has common movement goals. Oh, that's really tight. People do feel deeply connected in a movement. They are aligning various strategies and policies towards common goals, and these are some of the basic elements of building a movement that we think are important. The builders themselves. Movement builders are constantly engaged core allies, the public, and people in positions of power to address systemic problems and promote alternative visions. So there's the movement, and there are the builders of the movement. That's all of us as individuals and the work that we can do collectively to, in fact, dramatically change society. And this is what happens in movements. They change the world. They change society. They change the way we see our very daily existence. So the hope is that you've got something out of this conversation, that there's some knowledge that you've gotten that you, in fact, can use today, but to translate into the rest of the work that you do here in Missouri, that you found some relevancy in what you do, that this has been worth your time. Perhaps a new perspective has been opened up to you. And we certainly hope that it generates a national discussion on justice here in Missouri, and that you found at least one actionable item that you can, in fact, take a look at. And in some small way, we inspired you. So what can we do? I wanted to make sure we left you with at least some sense of clear direction. Number one, this question of a collective consciousness. where we're all on the same page and recognize there is no them, there's only us. It's about justice and elimination of injustice. It's about equity and social justice and human rights. That you find the political will and that you encourage your politicians to find the political will and the nerve, I guess, to step up to the plate and be the leadership in forming this new movement. That we all become true ambassadors for health, equity, and social justice. Redefining your personal professional values. We talked last night about the Organization of Community Justice and the new training. And we have several people in the room who are now facilitators. Where are you? Is there any raise your hands high. This is a new certification accreditation for an organization that talks about community justice training, and it came through a discussion that we were having around ending racism training that we did in Louisville, and this really, I think, it really advanced an incredible opportunity to spread that word through this community. Is just fantastic. Remember, there's know them, only us, and we look at this quote from Janetta Cole, who was the president of Spelman College, and she said, "Start looking at the world as if we all came from one womb." Because we kind of did in some sense or another. Remember, the power of one is real. This has to be a movement, and you need to be willing to take the risk. And this is the Cape of Good Hope in South Africa. We always try to make sure we leave any presentation with a sense of hope. There is always hope. One of the most beautiful spots on the planet. Now I'm going to ask you to take a slight risk with me. In a prior life, I did some clinical hypnosis, but I promise I'm not going to hypnotize you. So I would ask you to take a deep breath and close your eyes and just sit for a minute with the notion of a collective consciousness and what health equity should look like or can look like in your imagination while I share this thought with you about taking risk, which is certainly the next step in this. To laugh is to risk appearing a fool. To weep is to risk appearing sentimental. To reach out for another is to risk involvement. To expose your feelings is to risk exposing your true self. To place your ideas, your dreams before the crowd is to risk their loss. To love is to risk not being loved in return. To live is to risk dying. To hope is to risk despair. To try is to risk failure, but risks must be taken because the greatest hazard in life is to risk nothing. The person who risks nothing, does nothing, has nothing, and is nothing. He may avoid suffering and sorrow, but he simply can't learn, feel, change, grow, love, or live. Chained by his certitude, he is a slave. He has forfeited his freedom, for only a person who risks is free. Take a deep breath, open your eyes. And we say thank you very much and live long and prosper. Thank you. Thank you. We have time for Q&A? We have time for Q&A? Yes. Thank you. That's really warm. Thank you. My wife and I didn't introduce Denise. I'm sorry about this. This is my life partner and business partner, Denise. Denise, stand up. Say hi. Denise is working out so hard she tore a cartilage in her knee, so that tape thing she's got on there is from the therapist. She's trying to cover it up because it thinks it looks bad. Yeah, but I clearly love her. She's a wonderful person, and we have a great team, and we do great work together. Thank you for being here. So, questions, comments? Yes, sir.
I wanted to ask you, with your working with Dr. Satcher, your historical knowledge, what do you feel the impact of Supreme Court's rulings? Yeah, I'm asking.
Yeah, no.
Dealing with affirmative action, the impact will be on public just your general thoughts.
Yeah, I think it's absolutely reprehensible. I'm with Sotomayor on this one. It was absolutely the wrong step to take. My personal involvement in this goes back to the Bakke decision. Many of you may have never heard of Bakke decision. This was when I was a medical student in New Jersey. The Bakke decision was about a young man named Alan Bakke, who claimed that he was blocked out of medical school because spots were given to black students who were less deserving than he was. And it went through the court system, and in fact, it was upheld. The Bakke decision was upheld. It put a damper into the recruitment efforts of medical schools all over the country to get African American students in to deal with these issues. And one of the things that we all recognize, I think, is that underrepresented populations are more likely to provide service to those populations if they go through medical school, law school, dental school, whatever. I mean, it's been proven. Better service, hopefully, but certainly service when others would not. The notion that now Michigan, I think it is, can eliminate the use of race as a part of their decision-making process is a mistake. It's absolutely wrong. We are nowhere near where we need to be, but we can say we have a completely open society and everybody can compete on their merit. It's like we were discussing this yesterday again. The old image of running a 100-meter dash. Everybody's on the starting line, and this community, in this case, African Americans, Latinos, et cetera, are 15 yards behind the starting line. And the gun goes off, and you expect everybody to have an equal opportunity to win the game. It ain't gonna happen. It can't happen. So it is a wrong move, and I think we collectively need to make some noise about it, whether it's through your legislators or through I don't know what mechanisms you have at the local level, but I think it ought to be a continued focus on the wrongness, if you will, or the lack of progress in this area based upon that we're not where we need to be to have just open, opportunities at the same speed and same length of race to get to the finish line. And I'm sure David Satcher feels the same way. I won't speak for him, but I would think he would feel the same way. Other questions? Yes, ma'am.
Thank you so much for your work, first of all. And second of all, how do you suggest we help communities weigh a business coming in with the promise of jobs that might lead to environmental degradation and then health consequences?
Yeah, these are great questions. And
Repeat the question.
Yes, the question was, how can you balance business coming into a community with the promise of jobs and issues around environmental impact? I'd take it a step further in the context of fast food joints or something I thought about in the past. The argument that we don't need any more fast food restaurants in this neighborhood, but someone comes in and says, well, I can create 50 new jobs here, and that's really important, but the 50 new jobs are in an industry that at this point is not regulated to the point that it provides real support for people's health and nutrition, and it's part of the problem. So how do you weigh that? And that those really need to be local decisions that engage communities and get involved in and understand the implications of both sides, and then take responsibility for their positions. I mean, far be it from me to tell a neighborhood in West Louisville, no more, although we've talked about that, no more fast food restaurants. You got enough. So any more that comes in there, we're not going to give them, a business license to produce, to do anything in this community because it's just harmful to the community. There's environmental impact assessments. There's something called health impact assessments, which is really based upon the environmental health impact assessment model, and says that anything that you look at, whether it's creation of a business, a building, a process, a service, has to be looked at in terms of its impact on the health of that community. And usually it's being used in communities that are depressed and marginalized. So that would be the best opportunity to put a process in place to look at it. So the business comes in and says, I want to put this business here. Go through a health impact assessment initiative. There was a group in Louisville. They wanted to open another liquor store. That's one business closed, and they tried to move it. The community got together and through some really creative organizing, decided we've had enough liquor stores. We're not having another liquor store in this community. They went to their council person. They advocated. They organized. They marched. They figured it. That liquor store never opened up because the community took charge of that situation and they were engaged and knew how to talk to the political leadership to get them engaged in the process, and was very effective. So that's something that's available to us, as all of us. But again, the health impact assessment piece is something that can be done, is being done around the country. Yes, ma'am.
Thanks so much for your work, and I'm just thrilled to be able to hear you talk more about it. I wonder if you could comment a little bit on the work in Louisville that you and the health department did with mapping the different neighborhoods and looking at social determinants and how that impacted longevity and all of those things. And specifically, what the next steps were. How did that change things for Louisville, and how can you use that as a model in other communities to bring about change on health issues and sort of social justice issues?
Yeah, can you hear me still? If I move away from the microphone. Yes? Can you hear me? Yes. So when I took the position in Louisville, there were no centers as yet around the country. We didn't have any resources to do the work that we felt we needed to do. So we hit on this idea of using GIS mapping. We put together a database of health status information in that population, and then translated them into GIS maps. Again, for those who've never seen one, it's taking data, numbers, bar graphs, line graphs, and turning them into maps with multiple colors on them, and you can then overlay things. So we would take a GIS map of hypertension in Louisville, and then it'd be one particular place where the darker the color, the more intense the issue. So there's one particular community that had very, very dark color for hypertension. Then we did cardiovascular, MIs, heart attacks, same map. Then we did infant mortality, same map. Then we did poverty in children, same map. And then so we stacked on top of each other, and then overlaid the Metro Council districts, and then presented that as a budget hearing to our council when it came time for us to find some resources. They were so overwhelmed by what they saw, we got about $1.5 million to open the Center for Health Equity. Then we, over the next year or two, we continued to do the work of analysis and presented some plans back to the council based upon the money they gave us to open the thing in the first place, and got more resources. I think the other important thing we did was the directorship and the staff positions in the Center for Health Equity are line items. They're not grants. So we didn't ask for a grant from the city. It's a part of the general fund budget of Jefferson County now. And unless somebody comes along and changes the structure of the budget in the organization, it'll be there. It'll be sustained. Subsequently, they went after grants and have gotten. We did REACH grant, community splitting prevention to work, community transformation grants. So it's been very effective in its own sustainability.
But what I also want to say too, and I don't know if people can hear me, but taking that medical, the health status information, and even combining it with your questions and saying, in that area, how many liquor stores are there? Or how many fast food? Or do you have a big box store? Or any of those things, to see that the things that you need weren't in the dark colors. The things that you really need. So how many gyms are in that area? How many parks are in that area? How much, how involved have police been in a certain area? So those GIS mappings with maps, when you start placing them atop each other, it can tell you a lot. I mean, it's the facts. You can't dispute the facts. So I think in Louisville and even in Portland, Oregon, where we found it to be really successful, is that legislators, I mean, you just put this map up there. I mean, you put it on a billboard in their area, and it's like shaming them, kind of, because they've got to do something. There is no park in this area for this amount of miles. So the GIS mapping becomes very effective. And I think why we put Portland up all the time is because they took it one step further. This is an accessible database by the community that you can say, you know, I live on Broad Street, 3905 Broad Street. I want to bring up what's happening around me in 3905 Broad Street. So now I'm empowered with the information, and not only is the health department going to show up at the meeting, but I'm going to show up at the meeting and say, you know what, on Broad Street, I so do not want another, I don't know, Arby's or Kentucky Fried Chicken, because I know what's happening in my community. So the GIS mapping's really just taken off in so many communities, but I think Portland has done it right if you're interested in that area.
I remember looking at the face of the council, the commissioners who were responsible for this particular district that had such a bad, just a bad profile. It was like, I can't believe what I'm looking at. And whether it was shame or concern or commitment, they put their efforts into making a difference because of what they saw on the GIS maps. Powerful stuff. Any more questions? I'm sorry. Oh, yes. Oh, that's it too. Yes, ma'am. Yes. Yeah.
Thank you. I have a lot of hope and faith in local systems and change and being able to initiate change on the local level as far as preventing a liquor store from moving in or organizing communities to keep certain corporations out of the community. One thing that I'm fearful of is more on a national level. There was a recent study that just was making its rounds on the internet about how Princeton University showed that we actually have an oligarchy and not a democracy in the United States, and there's very few wealthy people that control public policy on the national level. As far as some of the Supreme Court decisions as well that have come down as far as campaign finance reform and things like that. So I'm fearful of the future in that regard, and I'm wondering if you could speak about what kind of movements, collective movements, are needed to combat that, combat those issues.
Yeah, I think the movement that we're speaking of. Did you hear the question in the back, the other side of the room? So what we're talking about here is a movement based upon social justice and health equity and human rights. There are multiple organizations all over the country who do similar work, but don't talk to each other. So one of the issues that we have is how do we in fact connect as a public health or a clinical service provider population with jobs for justice and human rights for all and whatever the organizations are that are out there doing this work and regularly organizing. We expand the movement by our connection to those organizations who are doing this work anyway. There is no doubt about the fact that nationally we have to find a way to make some changes in the way this system operates. As I said in my definition of health inequities, it is systemic. It means it was built, it was created by people, it was constructed in such a way to benefit certain people in this community, in this nation. Well, we have to shift that whole direction of how we live our lives. No one said this is an easy process. Civil rights movement organized hundreds of thousands of people over the United States and marched. And I'm not saying that the 60s marching is what we need to do, but for that era, they marched, they organized, they went to jail, they cajoled, they convinced, they moved on Supreme Court, they moved on the president, and the president, pushed the Civil Rights Act in 1964. So it is that kind of mass movement that has to happen, starting at the local level with what's going on in this room, the people who are here and who they represent, and each of us being connected to represent our groups that we know about in our communities. And there are some national efforts around understanding this issue. Healthy People 2020, which is the nation's health plan, says creating health equity is what we're going to do for the next 10 years. Now, I'm not saying that's the be-all and the end-all. The Centers for Disease Control has a pyramid of health outcomes. And on the bottom of the pyramid, the base of the pyramid, is socioeconomic status and poverty elimination. But they've not yet moved to implement that. So there are some guidelines out there. The American Public Health Association has said we are going to be the healthiest nation in a generation, and we have to find a way to create health equity and social justice. So some of the national organizations are ready to get involved in the movement. Now, who's going to be the linchpin or where the linchpin comes from, I don't know. But that has to happen. I agree with you that as long as we have this what they describe an oligarchy, we're just going to have continued problems. I asked a question recently in another setting. Is it possible to have health equity in this political and economic environment? And I'm not going to answer that question. That's for you to think about. How do we get there?
Before Dr. Edison closes, I just want to say that one of the reasons we even chose to come back to Missouri, I'll just put it out there, Dr. Troutman and I are only not married, but we're business partners, but one of the reasons that we chose to come to be here today was for what you're doing this afternoon, that we really do think is the start, because everybody in this room is doing good work. It's sometimes the communication of what you're doing and the willingness to work with each other to one goal is what we don't see around the country, because we leave and then, you know, you go off and you go off and you go off and we talk about connection, but we really aren't. And so what's going to happen this afternoon is where that question mark gets taken away, because you're going to have the opportunity to share with each other what you're doing, and not only share, but start a meaningful collaboration, saying, you know what, I can work with you as a hospital system, I can work with you as a university system, I can work with you as a nonprofit, I can work with you as a student, I can work with you. And so that's what we thought was really thrilling to be a part of it and to start. And so we just want to commend you before you close on that.
Thank you for that, Denise. And we're really thrilled to have you here and to be a part.
One last point. It goes directly to what she said. That is, remember that the leadership might come and go, but the process has to stay alive. So as you're thinking about constructing the interactions that you're developing, it has to be one that can sustain itself if the leader who happens to be there today is not there tomorrow. Thank you.
Thank you.